should write. It'll all be fine. Easy ones, just write the answer. Whatever comes to your mind, write the answer. All of them are previous questions, PYQs. Fine. Good evening, Swati. I have to start with the bouncer, right? So do you guys don't forget me. The first question itself, you must have written it as the right answer, and it looks like a wrong answer. If you write a right answer, you are correct, right? You have to have the confidence. You have to have the confidence that you are correct and I am wrong, right? So the first question, I did mark it wrong. The answer, whatever you guys chose, is the correct answer, right? It's in secretory vesicle. Hello, love is, I don't know the full name there. Fine, right? It's a secretory vesicle. What you guys wrote is obviously the correct answer, right? So have confidence, right? Your examiner might be wrong, still whatever you read will be correct. Books, you read books, so definitely books are going to be correct. Than an individual, right? Okay. So this is an electron microscopic images. Of late in NEET exam, INICET exam also, they are trying to push an electron microscopy. God only knows what is the reason of electron microscopy, right? If you zoom the image, you can easily see them. I'm having a membrane-bound vesicle, and inside them there are tiny substances, right? These are your secretory vesicles. Secretory granules, they are there. So these secretory granules, on an impulse or when a receptor gets activated, these are going to release. Do you have any idea of whatever you read in physiology, which ion will help in the secretion of these granules? If you have to link one more subject there, calcium, right? Perfect. So whenever a receptor, I don't know what granule it is, so I'll not be able to say what receptor and what growth factor. So when a growth factor fits in, activates some receptors, let's say if it's an acetylcholine in your neuromuscular junction, calcium comes, calcium degranulates. So do remember this. See, calcium has the role of releasing everything, activating everything. That's why in necrosis apoptosis also calcium was very important, right? Calcium was very important. So this is just a secretory granule. As you guys said, calcium is the person which will help me degranulate. Calcium has that intrinsic property, which will be using it in different places. Fine. Okay, as the first one. Most of them will be easy questions, so previous year questions only. I just want you to read the question carefully and then write the answer. That's all. I won't make mistakes, hopefully, from now on. I am correct. Don't think that I marked again wrong, right? I am correct. This was also a repeat question. See, whenever you have a repeat question, please don't make mistakes in them. Read them, completely finish them. That should be like a golden mine for you. You can score definitely easily well, right? I'll end the poll. See, I'll not give a leaderboard every time. Maybe at the end of the class, if you guys want a leaderboard, I'll give. Fine. No, Sarvesh, not be. I'll come to it. Okay. Good evening, Shekhar. And because it's for self-improvement than boasting who is the first rank. I'll tell at the last, I'll release the leaderboard. If you want to stay, you can stay. If you don't want to stay, if you just want to improve yourself, you can leave. Right? Then I'll show the leaderboard for whoever is interested. The question is asking about a DIC. What happens is when you see a question, I'm sure that all of you here knows the topic of DIC. So automatically you'll go to your investigation point. D-dimer, FDPs. These are two things will come to your mind, right? These are two things will come to your mind. So we'll say that, okay, FDP should be the probable answer. But there's a twist in the question. The question is not asking about diagnosis. What is the question asking about? The question is asking about bleeding, right? So what is FDP? Can you expand FDP? FDP is your fibrin degradation products, right? So if I say FDP, am I right in saying that it is going to help in, you tell me which is going to help. It will help in clot formation or clot lysis. Where do they play a role? Formation or lysis? Perfect, it is lysis. All of you guys know it is lysis, right? So if it is clot lysis, does it have any role in bleeding or stopping bleeding? It's a clot lysis product, right? Does it have any role in stopping bleeding? No, it doesn't, right? So the question is about bleeding. I'm not asking about the diagnosis. Diagnosis is written in DAC. I'm not asking about how I'm going to arrive to the diagnosis. The question is about what is going to cause bleeding. So when do you think we'll have bleeding? Defect in clot lysis or defect in clotting? It has to be a defect in clotting, right? So which of the following will be the best one to say clotting will be abnormal? Answer should be your option A, fibrinogen. Because what is clot? Clot is nothing but fibrinogen to fibrin. So if I say, yes, Aditi, clot breaking will occur, that will increase the FDP, fine. So if I say when fibrinogen is absent, do you think clotting will happen properly? Definitely no, right? So the question is about that. I'm having a defect, DIC is the disease, but I'm not asking the diagnosis of the disease. I'm asking the symptom of bleeding. Why is it happening? If the question is about bleeding, it's about decreased fibrinogen and not my FDP or my D dimer. Fine. Got it, Pravesh? Okay, Sarvesh, I think Sarvesh, right? Got it? Fine. So read the question carefully. If the question is asking about bleeding, you're going to write about the bleeding only, not the disease. And it is reduced fibrinogen, which determines how the patient is going to bleed or not. That's the reason we transfuse fibrinogen as well for treatment, right? The patient has a bleeding. I should not have internal bleeding in the CNS. So I supplement my fibrin FFPs, fresh frozen plasma, cryoprecipitate. I'm aiming to increase fibrinogen. So this is my goal as well. So I'm going to look at this, and my goal of treatment is going to be that as well. I give FFPs, fresh frozen plasma. You give cryoprecipitate. We might see them sometime later, what is there. But in both of them, I will have good amount of fibrinogen. My goal is to treat and increase fibrinogen so that clotting will happen, right? Next thing, I will not prefer a vitamin K here initially because what happens, see, here, what is the defect? Reducing clotting factor or reducing reduction in vitamin K? What is the defect here in DIC? In DIC, the defect is going to be my reducing the clotting factor, right? I'm having consumption coagulopathy, platelets gone, clotting factor gone. Vitamin K is not consumed. So I don't expect every patient to be intrinsically deficient with vitamin K, right? So vitamin K is normal. I don't have clotting factor. So the best thing is to substitute the clotting factor, right? Rather than giving vitamin K. Got it? Okay. So if I'm going to say I'm having a patient with DIC, we'll see some MCQs surrounding DIC. What will be the best test for DIC? D-dimer or FDP? The best test is going to be D-dimer, right? Obviously D-dimer. D-dimer is the best one. FDP is a sensitive one. It's a cheaper alternative. That's all. Fine. Okay, fine. I'll come back to it. I'll just repeat whatever I said. See, when I'm having DIC, in DIC, the other name I'm sure you know, it's consumption coagulopathy, right? It consumes everything. It's in consumption coagulopathy. So what happens is, I'm going to have clot inside the body. That's disseminated intravascular coagulation. When the clot happens, there will be consumption of clotting factors. It'll consume everything. Once it consumes everything, it'll consume everything, including my fibrinogen also. Fibrinogen also will be utilized in the clot formation, right? So when this clot breaks, okay, when this clot breaks, I will have FDPs. Okay, I'll have FDPs. So when I see FDP, I'm going to say that clot broke, that's all. Okay, I'll come to a doom. The clot broke, that's all I can say. Fine. When I look at FDP, I cannot say it has consumed everything. Just tell me this answer to this question, Aditi. I'm having two clots in the body. The clot breaks. Will the FDP elevate? Randomly, I'm saying two clots. Will the FDP elevate? It will elevate. Why not? It's a clot. It is lysed. FDP will elevate. Two clots, it will elevate. 20 clots, it will elevate. 100 clots, it will elevate. So am I right in saying that for two clots, I will not consume every clotting factor? Yes, correct. I'll not consume every clotting factor, right? But when I'll consume every clotting factor, I'm going to consume everything. Like 100 clots are there, everything is consumed. So what determines bleeding is not my FDP. It will be elevated in n number of clots. When this guy goes down, I'm going to have a symptom of bleeding. So bleeding is determined on the fibrinogen levels and not on the FDP levels. Got it, Aditi? Okay, great. So the other organelle, the first image, Doom, what I told was like, I'm not able to say what organelle it is. It could be even a neuron end. Since in the electron microscopy, I don't have the surrounding thing to say what it is. Fine. Just a secretory vesicle, that's all. Okay, great. Fine. Next question. Again, read the question carefully. These are easy ones. Just write the answer. I'll create a poll. Okay, we'll end the poll. Yeah, I'll mention PTH. Your Shankar is correct. Fine. So see, most of you who wrote option A as the answer, you have missed this part, right? The question is not asking mucin. The question is asking acid mucin. So which means it's something different. We'll look at what it is. PAS stains mucin, correct? There's no doubt about that. Fine. PA is going to stain my neutral mucin. It also stains acid mucin, but not all the acid mucin. Fine. That's the only problem here. So if I'm asking just mucin, I will prefer PAs only. Since the question is about acid mucin, I'm going to have know a little bit more about mucin stains. Then you can easily write the answer. Fine. So when I take any mucin stain, let's assume this is mucin. I have different types of mucin. Like from our discussion, we know that we have acid mucin, we have neutral mucin. Okay. So where do we see neutral mucinous? We will see neutral mucin in the entire GIT and prostate. The location is important. We have it in GIT and we have it in prostate. As you guys know, neutral mucin is going to be positive for PAS. They'll be negative for Alcian blue, right? This guy will be PAS positive, but I'll just write ALB for Alcian blue, or just AB for Alcian blue, and Alcian blue negative. Fine. So neutral mucin will be like this. We'll come to Barrett's soon. Fine. So when I say as Barrett's is not a normal thing, it's an abnormal thing. Yeah, Barrett's is acidic mucin. Perfect. So when I say acidic mucin, I'm going to have different types of acidic mucin. Okay. So I'll have acid mucin non-sulfated, acid mesenchymal mucin, acid mucin sulfated, acid mucin connective tissue. We have different types of mucin. We have an acid mucin non-sulfated, I like SO4 non-sulfated. We have acid mucin which can be sulfated. We have acid mesenchymal mucin, right? We have different types of acid mucin. All of them are acid mucins only. So when I have a non-sulfated acid mucin, I see them in the gallbladder and in intestinal metaplasia. Can I call Barrett's as intestinal metaplasia? Is Barrett's intestinal metaplasia? Yes, right. So acid non-sulfated mucin, I'll see in gallbladder, normal gallbladder, as well as an adenocarcinoma of gallbladder, whatever it is, and I'll see them in intestinal metaplasia. Okay. Intestinal metaplasia can happen in the esophagus, which is Barrett's. Intestinal metaplasia can also happen in stomach as a result of peptic ulcer. In both these places, this is going to be positive for AB, Alcian blue, as well as PAS. This is dual positive, which means Barrett's will be dual positive, right? Barrett's will be positive for both. When I come to acid sulfate and mucin, I see them in the GI adenocarcinomas. This is normal GIT. When I sulfated mucin, I'll be seeing in entire GI adenocarcinomas. It's an abnormal thing, right? It's an abnormal thing. Here they are positive for PAS and they are positive for Alcian blue, but at a different pH. This also will be positive for both AB positive, PAS positive. Fine. But when I take an acid mesenchymal mucin, like have you heard about materials like keratin sulfate, dermatin sulfate, hyaluronic acid? What group of substances are these? Glycosaminoglycans, right? So am I right in saying that glycosaminoglycans will have mucin? It's like a jelly, right? It should have mucin component in them, right? So these glycosaminoglycans are seen in my mesenchymal tissue, connective tissue, right? So these glycosaminoglycans are this. They are seen in connective tissue. They're just your proteoglycans, hyaluronic acid. Okay. So they also will have mucin background and they also be positive. But this glycosaminoglycans is going to be positive only for Alcian blue and they'll be negative for PAs. They'll be Alcian blue positive, but they'll be PAs negative. Okay, they're going to be PAs negative. That's the reason of the three types of acid mucin. I have one type of acid mucin which is PAs negative. So we'll go back to the question. It's acid mucin. PAs cannot be the answer, right? That's the reason PAs cannot be the answer. If it's general mucin, I would prefer a PAs, because do you think I'm going to use, let's go to the next slide. Do you think I'm going to use proteoglycans in any GI diagnosis? Proteoglycan stain? I don't want it, right? So for all intents and purposes, for diagnosis, PAs is more than enough. But for theoretical point of view, if I say acid mucin, I will prefer an Alcian blue. A neutral mucin, I'll prefer a PAs. Fine. I hope this is clear. Read the question carefully and write the answer. We look at the other options. Stains, mesenteric stains. It's a stain for, it's an easy one. It's a stain for collagen, right? That's a stain for collagen, which all of us know. Okay. Yeah, something called as PTH. PTH is a muscle stain. Okay. predominantly a muscle stain. PTH stands for phosphotungstic acid hematoxylin. It's a type of hematoxylin. It's a stain for skeletal muscle. Perfect. Perfect. Right? It's in phosphotungstic acid hematoxylin. It's an acid hematoxylin. That's all. Okay. It's a stain for your skeletal muscle. So I'm going to say it's a stain for skeletal muscle. Why I'm going to use skeletal muscle stain is, I'll say an accent, right? Why I'm going to use it's the same for skeletal muscle is skeletal muscle are striated, right? In the routine HNE, the striations are not so perfect. When you use a PTH, it will increase the appearance of striations. This is going to highlight the striations in the muscle. Okay. Yeah, perfect. So I don't want that for my normal microscopy. Normal microscopy, I know a biopsy from a skeletal muscle, I have history. So where it's going to be useful is in rhabdomyosarcoma. Because rhabdomyosarcoma is a sarcoma. Every sarcoma will be spindled out only. So when I do a PTH, if the cytoplasm shows striations, I can say that it was a rhabdomyosarcoma. The origin is a skeletal muscle, right? So PTH is going to be useful for rhabdomyosarcoma. I don't want an undergraduate to know this. I'll tell why as well. Okay, this is an old stain, right? All these have become outdated. I just was there in the question, so we are discussing. That's all. PTH is an outdated stain. The reason why I'm saying outdated is if you're having rhabdomyosarcoma, do you know any immunohistochemical marker? Any IHC marker for rhabdomyosarcoma? Desmin is a non-specific marker. We have something called as myogenin. Perfect. Vimentin is non-specific again. MyoD1, myogenin. These are better. So I'm having PTH. I'm having MyoD1. Which is better? Undoubtedly, MyoD1 is better, right? Because I'll say why it's better also. So I'm having a tumor, rhabdomyosarcoma, which I know is coming from my skeletal muscle. If it is well differentiated, I'll have striations. If the tumor is poorly differentiated, do you think striations will be there? The tumor is not well differentiated, striations will not be there. So PTH will not be positive always. Only in a well differentiated condition will be positive. But MyoD1 is an embryological marker. It's from embryology I say that if this is positive, it is a skeletal muscle. So well, moderately or poorly differentiated, MyoD1 will be positive. So why should I break my head? I have a better marker, I'm going to go with that. Right? There are two good markers for skeletal muscle differentiation, MyoD1 and myogenin. Okay. Both of them are equally good. Fine. Both MyoD1 as well as myogenin is equally good. It's just the comfort of the pathologist and the availability in the lab, right? Desmin I will not choose for the only reason Desmin is positive in your smooth muscle tumor as well as skeletal muscle tumor. So I cannot differentiate and say it's rhabdomyosarcoma. Vimentin is positive in every sarcoma, fibrosarcoma, leiomyosarcoma, rhabdomyosarcoma, everything. Everything will be positive. Again, it is a non-specific marker. Fine. Great. So this is about this question. We have discussed quite a few things surrounding the question. Okay. Okay. Write the correct answer. It's a simple one. You don't require 45 seconds. Only 30 seconds. I'll close in 30 seconds. Okay. You should not make mistakes in these questions. These are simple questions. Okay. Okay, I'll end the poll. The tumor with less propensity for lymphatic metastasis. Yeah, correct, Annexon. I'll come to it. Carcinoma goes with via lymphatics only. BCC generally doesn't metastasize. Right? This is one. BCC is locally invasive. It generally doesn't metastasize. We will understand why BCC doesn't metastasize also. Right? We need reason for everything. The problem is we are reading without reason. When it's memory, we tend to forget them very soon. We'll have a practical example to know why BCC doesn't metastasize, and also the real reason of why BCC doesn't metastasize. How many of you are Wolverine fans? X-Men fans, Wolverine fans, great, right? So the actor who played Wolverine is Hugh Jackman, right? Hugh Jackman had basal cell carcinoma. Hugh Jackman had basal carcinoma 6 times on his face, 6 times operated. So if I know that a cancer is going to spread, do you think I will do a minimal surgery or I'll do a wide local excision? You will do a wide local excision, right? You will do a radical surgery, right? Definitely. But Hugh Jackman face is still crystal clear, which means they are not excised wide locally, which means they're okay. It will come again locally. It doesn't matter. It doesn't spread. So from practical point of view, you're not going to forget. Treatment is just tiny, tiny excision. If you're having a tumor like this, let's assume this skin and this is a tumor. I'm just going to remove 1 millimeter surrounding the tumor. That's all. Because in the face, I cannot create a 2 centimeter or 3 centimeter margin in the face. Not possible. Thank goodness, basal cell carcinoma does not spread. If it spreads, it's going to disfigure the face for sure, right? So practical example, I know it doesn't spread. So I do a tiny, tiny thing. And I also know I said it's 6 times came, which means local recurrence is very, very common. Fine. No need anything, just surgery, that's all. No need chemo also, nothing is required, right? So if you remember basal cell carcinoma, if you know the microscopy of basal cell carcinoma, we'll know why it doesn't spread. See, we have to know why. That's why we read pathology, right? So this is my squamous epithelium, and you have basal cells like this. Okay. So if you remember the histopathology, what will you see in basal cell carcinoma? In basal carcinoma, you will have nests of basal cells. Yeah, palisading nucleus, yes, but you'll have nests of basal cells, right? Palisading, yes, absolutely, but I'll have basal cells like this. You'll have like round basals. Yeah, retraction artifact will be there. Everything will be there. And yes, in the corner, like all you guys said, I'll have palisading appearance, right? I'm having nests of cells. If you've seen basal carcinoma before, it's not just a nest of cell. They will be surrounded by a thick collagen, because basal cells lies on what? Normally, basal cells lie on what? They lie on my basement membrane, which is nothing but collagen, right? The same thing they're going to take and come away, which means I'll have a perfectly superb collagen surrounding every nest. Right? I'll have perfectly superb collagen surrounding every nest. Okay. So in order for it to spread, it has to break the collagen. That is not possible. That is not possible, right? It's perfect. It's perfectly encasing and going inside. That's why they don't spread, right? We have to know the reason why they don't spread. It'll have a perfect collagen here. It'll be surrounded by collagen because my basal layer also is having a collagen. So it's perfect. So they don't spread. They can't spread, right? They can't spread. They'll be just like that only. Fine. So now you'll not forget ever. You'll not even forget why it doesn't spread. And you'll not forget the microscopic appearance. I'll have a perfect round walls with collagen surrounding, which means blue cells with a pink surrounding in the dermis basal cell carcinoma. Right? So what I do, I leave 1 millimeter margin. If this is my tumor, I just cut this. That's all. I just cut this and throw it outside. It'll never come back. Why it will come back is I might have missed. See, what I'm having is this is a tumor. Okay. Let's assume this is the face skin. What is the cause of basal cell carcinoma? Etiology. What causes basal cell carcinoma? I'm sure you know. Sun, right? Perfect. That's all. Sun causes it. So am I right in saying that my sun caused a mutation here? Can the same sun cause a damage here also? I'll say 1.2 point. Yes, both areas it can cause damage. And I assume that this became a cancer now, right? But here, there might have been a genetic problem, but not become a cancer yet, right? So what happens is I'm removing this. So can this grow again? It will grow again. It's sun-related damage. I cannot keep on removing every part. But whatever is abnormal, I'll remove it. I'll wait. Let it come back. I'll remove it again. That's all. Right? That's the reason it recurs. Not because of incomplete surgery. Because this is called as in field cancerization. Right? It cancerizes the entire field, not just the tumor. Right? That's why it recurs back. Fine. So we know why it recurs. Okay, for glioma, see, I didn't say glioma for it doesn't spread. Glioma does spread. I'll come to Shubhra. Glioma does spread. What happens in glioma is, it is said that CNS has very less lymphatics. Glioma doesn't have a lymphatic spread, that's all. Right? Not that glioma will not spread at all. Glioma is a rare lymphatic spread because CNS doesn't have much lymphatics. I didn't say no lymphatics because the entire thing is changing. We are seeing lymphatics in CNS as well, but they don't have much lymphatics. So the propensity of lymphatic spread is less. But glioma from one cerebral hemisphere can go to another cerebral hemisphere. I am sure you must have read about butterfly tumor. Have you read about butterfly tumor? For sure, right? So it will spread. Glioma will spread. Have you read about drop metastasis? Medulloblastoma? You have read. So that's also glial-like tumor. Gliomas also can have dark metastasis. They don't spread via lymphatics because lymphatics is less, right? But they do spread. They do spread for sure, but they don't spread via lymphatics. That's all. Okay, got it. See, basal cell carcinoma, since you asked the genes, there is a pathway called as Sonic Hedgehog pathway. Okay, how many of you are fans of Sonic Hedgehog, the cartoon character? None of you guys. It's Sonic Hedgehog pathway, and the gene is PTCH, patch gene. Okay, patch gene and Sonic Hedgehog pathway. The Sonic Hedgehog, the character came from looking at this, right? We'll take some other time to say why it is named so, right? Okay, the syndrome is, yeah, Gorlin syndrome. Gorlin syndrome is congenital. This can be acquired by UV rays also. Acquired is definitely much more common than your congenital Gorlin syndrome. Fine, got it? Great. Okay. Yeah, medulloblastom also has that.